Welcome. In this session, we will be discussing congenital cranial dysinnervation disorders and chronic progressive external ophthalmoplegia. Congenital cranial dysinnervation disorder or CCDDs are congenital defects of one or more cranial nerves with nuclear hypoplasia, misdirection of the cranial nerve, or even absence of the cranial nerve, and it is often associated with secondary stiffening or contracture of the abnormally innervated extraocular muscle. And among CCDDs, we have Duane's retraction syndrome, congenital fibrosis of extraocular muscles, and Moebius syndrome. Duane's retraction syndrome, also known as DRS, is a CCDD whose clinical features essentially arise from two pathogenetic defects. The first one is an absent or hypoplastic 6 cranial nerve nucleus leading to variable hypoinnervation of the lateral rectus muscle by the 6 cranial nerves, and this hypoinnervation results in contracture of the lateral rectus muscle. The second pathogenetic defect is that the lateral rectus muscle is instead supplied by a branch from the inferior division of the third cranial nerve, which in addition also supplies the medial rectus muscle. The most important clinical feature of DRS is unattempted adduction of the affected eye. There is co-contraction of the medial and the lateral rectus muscles, which are both supplied by the third cranial nerve in DRS, with retraction of the globe posteriorly into the orbit, resulting in narrowing of the palpebral fissure. The retraction of the globe posteriorly into the orbit can be better observed in the worm's eye view, which we have discussed in the session on examination of the orbit in oculoplasty section. And on slit beam examination, the retraction will be seen as a discontinuity between the portion of the slit projecting on the cornea and the portion of the slit projecting on the lid margin. This photograph shows a patient with DRS in the left eye, and we find narrowing of the palpebral fissure on attempted adduction of the left eye from the primary position, and this narrowing of the palpebral fissure is caused by retraction of the globe posteriorly into the orbit. And from the retraction of the globe found in this syndrome is called Duane's retraction syndrome. In addition, in the adducted position, there are upshoot or downshoot movements of the affected eye because of slippage of the globe against the tight lateral rectus muscle. This photograph shows a patient with DRS in the right eye, and on attempted adduction of the right eye elevates or depresses, and this elevation or depression is called upshoot and downshoot movement of DRS, and this occurs because in an adducted position the already contracted lateral rectus muscle becomes further tight, and the globe can slip above or below this tightened lateral rectus muscle, resulting in upshoot and downshoot. DRS patient can also have limitation of abduction, limitation of adduction, or limitation of both abduction and adduction, with esotropia, exotropia, or orthotropia in the primary position. And in most DRS patients, the magnitude of primary position heterotropia is usually small and does not correlate with the much larger limitation of ductions. DRS patients usually have single binocular vision with good stereopsis because of compensatory head posture. Demographic features of DRS are as follows. Females are more commonly affected. The left eye is more commonly involved. Most cases of DRS are sporadic, but 5 to 10% of DRS patients can have an autosomal dominant inheritance pattern. Most cases of DRS are unilateral, but 15% of DRS cases can be bilateral with asymmetric globe retraction between the two eyes. This photograph is of a bilateral DRS patient showing narrowing of the palpebral fissure of the right eye in left lateral gaze and narrowing of the palpebral fissure of the left eye on right lateral gaze. Most DRS cases are isolated, but some DRS patients can have associated golden heart syndrome and Wilder-Wang syndrome. Wilder-Wang syndrome is an association of DRS with Klippel-Feil syndrome or fused cervical vertebra and congenital hearing loss. The ocular alignment and movement patterns in DRS patients belong to a continuous spectrum, but three types can be described. In type 1 DRS patients, abduction deficit predominates, and these patients may have a primary position esotropia, and this is said to be due to a mild CN3 misinnervation of the lateral rectus muscle, and thus these patients have less co-contraction of the lateral rectus and medial rectus muscles. So in type 1 DRS we get less globe retraction as compared to type 2 and type 3 DRS patients. Type 1 DRS is the most common type of DRS, constituting 85% of all DRS patients. And in infants with paralytic esotropia, it is said that type 1 DRS is more common than congenital 6 cranial nerve palsy. In type 2 DRS, adduction deficit predominates, and these patients may have primary position exotropia. And in these patients, it is said that the CN3 misinnervation of the lateral rectus muscle is moderate, resulting in more co-contraction of the lateral rectus and the medial rectus muscles, and thus these patients have more globe retraction than type 1 patients. But type 2 DRS is less common, comprising 14% of all DRS patients. Type 3 DRS patients have deficit of both abduction and adduction, and so their primary position ocular alignment can be orthotropia, esotropia or exotropia. And type 3 is the least common type of DRS, comprising 1% of all DRS patients. Synergistic divergence, also called ocular splits, is a rare form of CCDD which is often classified as a subtype of DRS. And these patients have primary position exotropia of the affected eye, and when the affected eye attempts to adduct during contralateral gaze, there is further abduction of the affected eye instead of adduction. So with attempted contralateral gaze, the two eyes move in opposite directions, and thus it is called ocular splits. Non-surgical treatment of DRS includes correction of refractive error if there is coexistent accommodative esotropia, because correction of refractive error minimizes accommodative convergence movement and so minimizes adduction-induced globe retraction. In DRS, surgery cannot correct the duction anomalies but can be instituted to correct primary position heterotropia, anomalous head position, globe retraction, upshoots and downshoots. In patients with type 1 DRS with primary position esotropia or contralateral head turn, ipsilateral medial rectus recession can be done, but efficacy of additional contralateral medial rectus recession cannot be predicted because of the underlying misinnervation. Transposition of vertical rectus muscles to the lateral rectus insertion can be done in an attempt to improve the abduction of the globe, but ipsilateral lateral rectus resection should not be done because that may increase globe retraction, and this is very important to remember. Similarly, in type 2 patients with primary position exotropia or ipsilateral head turn, ipsilateral lateral rectus recession can be done, but efficacy of additional contralateral lateral rectus recession cannot be predicted because of the underlying misinnervation. Ipsilateral medial rectus resection should not be done in an attempt to improve the limitation of adduction of the globe because that may increase globe retraction, and this is also very important to remember. So in DRS, resection of horizontal rectus muscle should be avoided because that may increase retraction of the globe. Retraction of globe in DRS can be treated by resection of both lateral rectus and medial rectus muscles, and upshoots and downshoots of DRS can also be treated by resection of both lateral and medial rectus muscles as well as by lateral rectus weakening of the affected eye. And this lateral rectus weakening can be done by horizontal splitting, also called Y-splitting of the lateral rectus muscle, retroequatorial fixation of the lateral rectus muscle, and in severe cases the lateral rectus muscle can be disinserted and fixated to the lateral orbital wall along with transposition of the vertical rectus muscle to the lateral rectus insertion to provide force of abduction. Congenital fibrosis of extraocular muscles or CFEOM is also a CCDD with defects in cranial nerves and their nuclei, particularly the third and the fourth cranial nerve. And because of this hypoinnervation, there is hypoplasia and fibrosis of the muscles supplied by this nerve. In contrast to CPEO, which we will be discussing later in this session, CFEOM presents at birth. Several types of CFEOM has been described. In CFEOM type 1, there is a bilateral CN3 defect, and this is autosomal dominant in inheritance. And these patients have bilateral ptosis, exotropia, hypotropia, and chin-up position. This photograph shows a patient with CFEOM type 1 with the ptotic eyelids lifted, showing hypotropia and exotropia of both the eyes. And upon release of the ptotic eyelids, the patient takes up a chin-up position. In type 2 CFEOM, we find bilateral defects in the third and fourth cranial nerves, and type 2 CFEOM is autosomal recessive in inheritance pattern. Type 3, type 4 and type 5 CFEOMs have also been described. Treatment of CFEOM is challenging and usually involves releasing restriction due to muscle fibrosis. Correction of ptosis may lead to exposure keratopathy and should be done very carefully. Moebius syndrome is another CCDD in which there is unilateral or bilateral dysgenesis of cranial nerves, and most commonly the 6th cranial nerve and the 7th cranial nerve are affected. Dysgenesis of other cranial nerves can also be present in a patient with Moebius syndrome, including the 3rd and the 4th cranial nerve. Clinical features of Moebius syndrome include mask-like faces and lack of ophthalmos because of involvement of the 7th cranial nerve. Mask-like faces implying lack of emotional expression, and this is the earliest feature to be recognized in a newborn infant. 3 patterns of ocular motility have been described in patients with Moebius syndrome. Some patients have orthotropia in primary position with complete abduction and adduction deficits, and this pattern is due to congenital defect in the gaze centers associated with the 6th cranial nerve nucleus. Some patients show large angle esotropia with cross fixation and preserved convergence, and these patients have tight medial rectus muscle because of long-standing large angle esotropia. These patients may resemble patients with infantile esotropia, but patients with infantile esotropia show normal abduction on Dahl's maneuver, which is limited in patients with Moebius syndrome. Few patients with Moebius syndrome can actually show a large angle exotropia with absence of convergence, probably because of involvement of the 3rd cranial nerve. In addition to cranial nerve defects, patients with Moebius syndrome can show limb, chest and tongue defects. This photograph shows a patient with Moebius syndrome with bilateral esotropia with cross fixation, lack of ophthalmos and anomalies of fingers. Treatment of patients with Moebius syndrome include bilateral medial rectus recession with vertical muscle transposition to the lateral rectus insertion in order to provide force of abduction or resection of lateral rectus muscle. Chronic progressive external ophthalmoplegia or CPEO is a myopathy and is not a CCDD. Patients with CPEO have a defect in their mitochondrial function, and this defect in mitochondrial function can be due to defects in either mitochondrial or nuclear genes. So CPEO cases can be either sporadic or familial, and familial cases of CPEO can have mitochondrial, autosomal dominant or autosomal recessive pattern of inheritance. Symptoms of CPEO usually begin in 2nd to 4th decades of life, unlike CFEOM, which presents at birth. CPEO starts with ptosis and gradually progresses to total paralysis of all extraocular muscles, which is bilaterally symmetrical. And so patients with CPEO usually does not complain of diplopia, and in addition, patients with CPEO can have generalized muscle weakness. CPEO is diagnosed by muscle biopsy showing ragged red fibers, specific mitochondrial DNA mutations, and electron microscopy studies showing inclusion bodies in affected mitochondria. And Kearns-Sayre syndrome is CPEO associated with pigmented retinopathy with constricted visual fields and ERG abnormalities, and cardiomyopathy, usually a heart block which is potentially lethal. In CPEO, treatment of ocular motility limitation is not promising, but many patients may require guarded upper eyelid elevation with frontalis sling to improve vision. Simultaneously, lower lid may need to be elevated to prevent dryness and risk of exposure keratitis arising from upper eyelid elevation. Cardiac evaluation is essential and mandatory in CPEO patients, and this is very important to remember. Strabismus can also occur following ocular surgery due to local anesthetic injection which can injure the inferior rectus muscle, and this is characterized by initial hypertrophy due to weakness of the inferior rectus muscle followed by hypertrophy due to restriction of the inferior rectus muscle. Conjunctival scarring following ocular surgery, particularly in the lateral canthal area, can also result in ocular motility limitation. Medial rectus muscle can be injured during pterygium surgery, and medial rectus can also be injured during endoscopic sinus surgery. Botulinum toxin injection for eyelids can diffuse to the extraocular muscles and can result in ocular movement limitation. Following refractive surgery for monovision, in which one eye is corrected for distance and the other eye is corrected for near, can disrupt fusion controlling a heterophoria, making a heterotropia manifest. And following refractive surgery for distance correction in both eyes, if a patient has pre-existing strabismus and starts fixating with the non-dominant eye following refractive surgery, diplopia can occur. Although magnitude of pre-existent strabismus may remain unchanged, and this is called fixation switch diplopia. Strabismus can occur following glaucoma valve surgery, and strabismus can also occur following retinal detachment surgery due to implantation of scleral buckles or development of epiretinal membrane, which can distort the fovea, resulting in metamorphopsia, which impairs fusion, controlling a heterophoria, making a heterotropia manifest. In these patients, there is disruption of central fusion with intact peripheral fusion, and prism therapy may not be effective as prism disrupts peripheral fusion, which when realigns, the central diplopia reappears. Other causes of strabismus and ocular motility disturbances, which we have discussed in the sections on neuro-ophthalmology and oculoplasty, include myasthenia gravis, internuclear ophthalmoplegia, superior oblique myokymia, ocular motor apraxia, ocular neuromyotonia, ocular movement limitation from orbital disorders such as tumor, trauma, inflammation, and infection, and supranuclear lesions causing strabismus and ocular motility limitation such as Q deviations, ocular tilt reactions, tonic deviations, gaze palsies, progressive supranuclear palsy, and dorsal midbrain syndrome. To recap the salient points, congenital cranial dysinnervation disorders or CCDDs include Duane's retraction syndrome or DRS, congenital fibrosis of extraocular muscles or CFEOM, and Moebius syndrome. DRS is caused by hypoplasia or aplasia of 6th cranial nerve and its nucleus, with the lateral rectus being supplied by a branch from the inferior division of the 3rd cranial nerve. DRS is characterized by retraction of the globe with narrowing of palpebral fissure on attempted adduction, upshoot and downshoot on attempted adduction, with or without limitation of abduction or adduction or both, and small angle heterotropia in primary position. CFEOM is caused by congenital defect of cranial nerves and their nuclei, usually the 3rd cranial nerve and less commonly the 4th cranial nerve. CFEOM is associated with hypoplasia and fibrosis of the hypoinnervated muscle, resulting in restrictive heterotropia. Several types of CFEOM have been described with their causative mutations. In Moebius syndrome, the 6th and 7th cranial nerve nuclei are usually congenitally defective, though other cranial nerve nuclei can also be defective. Moebius syndrome can present with lag ophthalmos, mask-like faces, large angle esotropia with cross-fixation, or orthotropia with horizontal gaze palsies. Chronic progressive external ophthalmoplegia or CPEO is due to mitochondrial dysfunction caused by nuclear or mitochondrial genetic defects. CPEO has onset in early adulthood and presents with insidious onset and gradually progressive bilaterally symmetric ptosis and palsy of all extraocular muscles. CPEO can be associated with pigmented retinopathy and cardiac conduction defects, and this is called Kearns-Sayre syndrome, and so cardiac evaluation is mandatory in all patients with CPEO. Post-operative strabismus can occur following local anesthesia injection, conjunctival scarring following ocular surgery, TDGM surgery, refractive surgery, glaucoma valve surgery, retinal detachment surgery with buccal implantation or epiretinal membrane formation, and botulinum toxin injection to the eyelids. Thank you for listening.